Make Dr. Parag host. Rakesh.
सर एक्चुअली मैं ट्रेन में चढ़ने जा रहा हूँ तो नेटवर्क मेरा इशू हो जाएगा। आपको मैं होस्ट बना दिया हूँ सर, बट मैं मीटिंग में रहूंगा।
अच्छा,
हाँ सर। हाँ
okay.
सर, थैंक यू।
Paras, Dr. Parag is going to show the slides, correct?
यस सर, यस।
So he has already joined. Na? I think I made him
हाँ सर।
co-host also.
हाँ यस सर।
Yeah. So Dr. Parag, you can share your screen and all by the time the students join.
Sure, sir.
So when we start, na, you just give 2 minutes for each slide. Okay. So how many questions, how many slides you have made?
For the spotters, I have 6 cases, and
Okay.
thereafter I have a discussion of about 50-60 slides odd.
Okay. Fine. So we will start that as soon as probably I think they got information at 9 o'clock or something. I don't know. I'll just find out. Once
Okay, no problems. I'm here.
few students they join, we will start it, and then you can continue with the discussion.
Sure, sir. Sure.
Rakesh, some problem?
No, sir.
Parag is not able to share the screen. Okay.
I'm ready,
So-
sir. As in
Okay.
when we.
I think we start now. Slowly
All
they
right.
will join. We'll see.
Sure, sir.
Huh? So each slide, okay, you give them 2 minutes for answer, and
Right,
then
sir.
you go for the next slide. So we'll
Sure.
finish this 6 slides.
And
Okay.
the and my part of the answers or the discussions will happen with the presentation later on. That's the way it works.
No, and after that, you start discussing each and every slide. What is the answer for that?
Okay.
And then the clinical questions we can ask.
Okay, sure.
Hmm? But
Right.
if your questions are, much better related to this, then I think it's better that you ask these questions and continue with your talk.
Right, sir. Sure.
Yeah. Okay. Fine.
Okay, so this is a 5-year-old child. I'll begin with the bread and butter of nuclear medicine. A 5-year-old child, febrile UTI. Please read the scan. You have 2 scans here.
Yes, sir, this is a renal scintigraphy chart showing the DMSA scan, which is on the left side of the scan. There is a, as a history suggests, there is a slight irregular shape of the left kidney, which is showing the photophenic area, and of that photophenic area may suggest that is the infective foci. And after the 6 month of follow-up, the scan shows the typical bean shaped left side kidney as well as the right side kidney. There is no background radiation present as such, and there is no bladder seen. So this is a DMSA scan. In baseline scan, there is a acute pyelonephritis, and after 6 months there is no cortical defect or scar seen. Hence patient is treated with antibiotic, responded to the antibiotics. And DMSA, it is a very particular to the attachment to the cortical and tubular cells. So this is the DMSA scan which showing the acute pyelonephritis.
Okay, that's perfect. I think that's a good explanation. Few technical terms you will need to get well versed with, which I will address as we proceed ahead with the talk. Shall I move on to the next case? All right. Yes, left hydronephrosis. Who would like to answer the scan?
Sir, this is again a renal scintigraphy graph, which on left upper corner showing the first phase of scintigraphy, that is a renal perfusion scan, which is done in a first 2 minutes. In this, there is a good perfusion on the good perfusion on the right side of the kidney, and left side kidney suggests a slight photopenic area with enlarged contour. And after at the last picture, there is a complete radio tracer is drained out. And second phase, just down that, there is a there is a cortical phase of the renal scintigraphy, which suggestive of enlarged left side of the kidney, and a radio tracer which is present more in cortical part and not still come into the pelvic part as the photo as a radio tracers trickle down the in the genitourinary system or in the ureter. uh, there is a increase in radio tracer activity in the left kidney parenchyma, and as time goes, it is accumulated in the pelvic LSL system as well as a renal unit, which suggestive of the right side PUJ obstruction. And again, in time activity curve, there is a on the right graph, right kidney graph, which is showing of greenish color, which shows peak uh, 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 peak at the 1 to 2 minutes, and then after that peak there is a excretory phase which is declining. But on left, that is left kidney, that is shown in the graph by the red curve, which is persistently high and going upward, that is suggestive of the PUJ obstruction in the left side. And on qualitative split function suggestive of 47 is to 52%, and GFR 39 is to 43.9%, which suggestive of fair preservation of the function of the left kidney.
All right. So we'll go on to the next slide now. Yes, another renogram.
I'm Dr. Premajan, sir. It's looked like a diuretic renogram scan, and it's a show in perfusion images. I'm not able to see clearly, sir, but and the images wise, in the perfusion images, it shows then right-sided delayed uptake was there, and left side is a good uptake was there, and in functional phases, the left side was is a good uptake, and the right side was no good uptake is there. And in the delayed phases, there is in curve images, they is showing the right side, left side there is a uptake is there, and there is no drainage pattern inside, and right side kidney there is a good drainage pattern is there, and there is in the numbers almost fair. Both the kidney shows good uptake, and the function is also same, nearby fairly equal. But the delayed, there is in the left side, there is a delayed drainage and diuretic TF is more like 120 is there, and right sided there is fairly fast drainage is there. In post-wide images also there is left side there is a pulling of the contrast is seen, pulling of the radioisotope is seen in the left side kidney. That is suggestive of obstruction and with the preserved parenchymal function on the left side.
All right. Shall we go to the next case, or do you want to discuss these cases as you have been reading these cases?
If you think that if you just want to give them some chance, finish these 6 cases and then you discuss why, what is an answer and how to read about.
Sure, sir. So I'll just go through all these cases and then I'll come back to each case and have a discussion on each of those cases.
Correct. Yeah.
Okay, anybody this scan?
Sir, this is a renal scintigraphy scan of looks like a transplanted kidney, which is taken from anterior side, and there is a the kidney's location is in pelvis, and small ureteric part has been seen, and as well as bladder with good drainage.
All right, I'll go to the next case.
Anyone can answer.
Yes,
Sir,
take it.
this is again a renal scintigraphy graph, scintigraphy of the right side implanted kidney in the iliac fossa, and in upper curve, which is showing a white curve once and a green color curve. White curve shows the perfusion, that is a blood flow in the iliac vessel, as well as sir, green curve suggestive of the blood flow in the transplanted in the graft, suggestive of uh, good blood flow, that is good perfusion in the upper graph, which is suggestive of perfusion graph, and down graph, which is showing the cortical uptake as well as the drainage pattern. In this, there is a slight brisk upstroke in the perfusion phase, which is continuously increasing, which suggestive of kind of obstructed pattern, which is suggestive of obstructive pattern. And sir, then sir, GFR is 127.82, and sir, it's look like obstructed kidney due to the maybe. Sir, this is obstructed type of graph.
All right. And I suppose this will be the last of it. Again, a transplanted kidney, just for a hint.
Sir, again, this is a renal scintigraphy of a transplanted kidney, which suggestive of perfusion phase, which shows very good perfusion in the graph, as well as in the cortical phase. There is a there is a good uptake in the graph, which suggestive of function, good function of the graph, and due to the good perfusion and function, this the good function, and but the tracer is also, radio tracer is also draining well into the bladder, but graph is having the time activity curve graph is having upstroke in the perfusion, as well as upstroke in the cortical, as well as excretory phase, which is a plateau, which is looks like equivocal pattern of the graph.
So do you have a conclusion to this scan?
Maybe, sir, this is due to the functional obstruction, which can be relieved after some time if graph as a we will give the time to graph to adjust to that area as well as the function of the ureter.
All right. I think we're done with all the cases here. Shall I go back case by case and then?
Yeah. So, Parag, what you do, you take one case, take one
Yeah.
student,
Sure.
and ask them the question. I mean,
Right.
what you think, and what should be the way to detect and how to go about.
Right, sir.
Okay, fine.
All right. Yeah.
Yeah.
So,
So whoever has answered this, who had answered?
Sir, me,
Yeah.
Dr. Rahul.
Okay,
Sir,
fine.
So Dr. Rahul, this is a DMSA scan. You rightly pointed that out. So your what would be the typical indications that you would use this scan for in your clinical practice?
Sir, DMSA scan indicated in acute pyelonephritis to detect the cortical defect or scar, to detect the function of transplanted kidneys, and detect the ectopic kidneys. In any case, sometime it may be detected in a traumatic cases also.
Okay, let me just refine a bit of your sentences here. One is, if you have already diagnosed acute pyelonephritis, you really don't need a scan. So you will do a DMSA scan when you have a febrile UTI, and your intention is to see if there's lower renal infection versus pyelonephritis, which is actual infection of the renal parenchyma. So that differentiation is going to be important for you from a clinical standpoint, because a pyelonephritis will need chemoprophylaxis, whereas a lower UTI infection or a cystitis typically will need just antibiotics or one course of antibiotics. So you don't use this scan in a known case of pyelonephritis. You would use it in a case of febrile UTI where pyelonephritis is suspected.
Yes.
Point two, you will, in this particular scan, when you do a baseline scan, as you rightly pointed out, there's a cortical defect. So how you read this scan is basically you say this is a DMSA scan. There are two scans shown here. You have a baseline scan and a second scan is done 6 months later. The isotope, the radiopharmaceutical used is technetium labeled DMSA. It's a renal static image, posterior view. This is the left kidney. This is the right kidney. So all renal scans, static, dynamic, all cases are by default in posterior view. So when you're looking from a posterior view, what you see on your left side is the left kidney. What you're seeing on the right side is your right kidney. Only in transplant renograms, you take anterior views because the kidney is closer to the anterior abdominal wall. And in that case, the right will be your left and the left will be your right.
Yes.
Yeah. So this is a posterior view. The left kidney shows photopenic areas along the cortex. The overall renal tracer extraction is fairly good in both kidneys. There is no background activity, which indicates that the kidney function is good. So when you interpret these scans, one is how is the relative function of each kidney? Second is, are there any cortical defects? Now, based on one scan, you cannot tell if this is acute pyelonephritis or this is a renal scar. Both will look similar on the scan as far as imaging is concerned. Of course, there's a clinical context that you have a febrile UTI, but if I'm speaking purely about the images, your single scan will not be able to differentiate a focus of acute pyelonephritis from a scar. And that is why you do a follow-up scan. In this particular case, baseline scan showing a defect. There is a follow-up scan which shows reversion of the defect or normalization of the scan. And in retrospect, hence, this particular defect was a focus of pyelonephritis and not a scar. Had this defect stayed persistent after 6 months of antibiotics on a follow-up scan, then I would have labeled that as scar. Right? That clear?
Yes. Yes.
Okay. Any more questions? Sir, would you have any questions? All right. So I'll move on to the next scan. This is a renal dynamic scan. So what are the typical indications of a renogram?
Sir,
Anybody?
to rule out the obstruction, PUJ obstruction, or it is a functional obstruction, we can do the renal scintigraphy, as well as for to check the function of transplanted graft, we can do the renal scintigraphy.
Okay, so a renogram, this is a dynamic renal scan or a renogram. So what isotope was used in this scan? What radiopharmaceutical is
Sir,
used in renal scan?
as saying the picture, there is not much background radioactivity. Most probably, it may be EC or MAG3 scan.
No, this is in fact, see, if you're saying the activity is not too much and hence you're saying this, if you look at the GFR values, it's an 83 GFR. So,
Yes.
so GFR, if you're using a MAG3 or an EC, you will get MAG3 clearance, which is equivalent to the enulined clearance, and it will be in the range of 250 to 350. Your
Yes.
DTPA will typically be in the range of 80 to 120. The older systems or some vendors, of course, don't have this place where you can give the name here, but this, okay, this is technetium labeled DTPA dynamic renogram. Indications of the scan, assessment of differential renal function, evaluation of obstructive uropathy, and specific evaluation of DTPA GFR. So this scan is the most objective and objective way of assessment of GFR of a patient, very, very frequently used in evaluation of prospective renal donors. So when you describe a renogram, you primarily look at three things. One, the qualitative parameters, which includes the perfusion phase and the cortical uptake and secretion phase. Two, the quantitative parameters, where you get these values here. And three is the renographic curve. You have to describe the scan in these three steps. And then any additional views. Sometimes you take lateral views, sometimes you take posterior views. Now, in this particular case, and these are the curves of the flow phase only. The white is the aorta, and these both are the kidney curves. So when you inject the isotope, the first phase you see is typically the flow phase. It's usually for about 1 to 2 minutes, and you compare the relative perfusion of both kidneys. This is not so important in a regular renogram, but this is very, very important in cases of transplant evaluation, because a lot depends on ATN versus rejection, and that primarily or rather solely rests on how good is the perfusion during the study. So the first phase of the renogram is the perfusion or the flow phase. The second phase is the uptake and excretion phase. They happen near simultaneously, so you do not have two set of images for uptake and excretion both. In this case, the perfusion to both kidneys is maintained. They show good homogeneous perfusion symmetrics. When you come to the uptake phase, you are seeing a photopenic area in the region of dilated pelvis. This was a left hydronephrotic kidney. So you're seeing photopenia or a cold area in the region of dilated pelvis. However, the uptake in the cortex in both kidneys is well maintained, as also reflected in these differential functions, 47 and 52. So the usual cutoffs that you follow is 44 to 56% is the normal range. Anything less than 44%, you will tend to call them as reduced function. So in this case, both kidneys show good uptake. There is a cold area or a photopenic area in the left pelvis, which shows progressive tracer accumulation on subsequent images as the dynamic imaging proceeds. The right kidney shows good uptake. There are no defects seen. Good cortical tracer uptake with rapid excretion, prompt excretion, no significant holdup of tracer in the right renal pelvis or the cortex at the dynamic study. But the left kidney shows significant tracer accumulation in the renal pelvis. The same is reflected in the renographic curves. The right kidney shows a good uptake, good peaking, followed by a smooth, rapid transit, that is excretion. Whereas the left kidney, there is progressive tracer accumulation, and the curve consequently reflects an upsloping or a rising curve or simply an obstructed curve. Post-void images, you still see the tracer accumulation in the left kidney, right kidney shows complete washout. The delayed images, there is still tracer accumulation in the left kidney compared to the right kidney, which shows complete washout. In this case, so your impression should be the left kidney shows hydronephrosis, there is good cortical function, but there is obstructed drainage. So comment on the function of the kidney, comment on the presence or absence of hydronephrosis, and finally comment on the obstruction versus non-obstructed system. Whereas the right kidney shows good function with no obstruction to the drainage. Now contrast that with this case. In this particular case, you are seeing a mild photopenia on the left side. Again, I mean, the flow phase description remains the same. There's good perfusion to both kidneys. There is good cortical tracer uptake in both kidneys. The differential function is good, 53% and 47% roughly. So the contribution of both kidneys is good. The uptake of both kidneys is good. But on the left kidney, there is progressive tracer accumulation in the region of photopenia in the pelvis. So there is hydronephrosis on the left side. Function of the left kidney is good. Renographic curve is of an obstructed pattern. But what happens when you look at the delayed images? Post-void images, there is still some tracer accumulation, but on the delayed images, there is washout of tracer from the left kidney. If you're looking at this, the relative intensities between the left and the right kidneys is largely similar, which means this kidney has left hydronephrosis, there's maintained cortical function, but the drainage is sluggish, but non-obstructed drainage. Had this been an obstructed system, there would have been tracer retention on the post-void as well as on the delayed images. So this patient has left hydronephrosis with a non-obstructed but sluggish drainage pattern. Imaging the post-void and delayed images and factoring in those during your scan interpretation is important. This is something called as a reservoir effect. This happens because of a passive pelvectasis where the renal pelvis is not really pushing down your tracer. There is accumulation, but there's no frank obstruction. As your urine outflow increases, as the pressure in the renal pelvis builds up, this washes out. And that is what you see on the delayed images.
But this on the parameters actually in the left side, the diuretic T off was so high, and in post-void image also left side the tracer is accumulated.
Yes, that's why you have that is the importance of these delayed images. There is something called as, so these curves, when they came up initially, the primary intention of these curves at that time is because you did not have imaging systems then. You just had counting probes, they would be positioned on your kidneys and you would generate these curves. And a rising obstruct curve like this would have been just called obstructed based purely on the curve pattern. But now that you have imaging along with this, curve alone is not an indicator for obstructed versus a non-obstructed system. So a new parameter, there are a lot of quantitative parameters that have come in. There's a new parameter called normalized residual activity, or NORA. So the NORA basically calculates the ratio of the kidney at 60 minutes versus the peak counts. And if you see the NORA, if in these particular cases, the washout will typically be seen on the 60-minute delayed images, and the NORA value will be less than 0.5. Any NORA of more than 0.7 is obstruction. NORA value of less than 0.5 is clearly non-obstructed. 0.5 to 0.7 still will be in an indeterminate fashion. This particular scan was an EC scan. It's still labeled as GFR because GE as a system does not have options to change the isotope yet. So we have to physically change it and write it as EC clearance or a MAC3 clearance on this scan. But it is an EC scan. The uptake values are fairly high. This is an EC scan.
So
right?
You can ask them the question related to renal scan, that when they can use it, or what are the findings, when they can follow up the patient.
All right. All right. So this, when do you use an EC scan versus when do you use a DTPA scan or a MAC3 for that matter?
Sir, if we are interested in to know about the GFR, then we would like to go for a DTPA scan, because DTPA tracer is more filtered through the glomerulus, so it will give the accurate GFR estimation. While MAG3 and EC, 20% of its portion goes through the glomerular filtration, but remaining percent it is good through the tubular secretion. So it is more particular for the tubular obstruction. To know the tubular obstruction, we would like to go for the MAG3 or EC scan.
Okay. No, I would like you to be more specific. In which clinical condition would you prefer an EC over a DTPA scan or a MAG3 over a DTPA scan?
Sir, in a PUJ obstruction, I would like to go for the MAG3 scan or EC scan. And in knowing the function of the post-transplant graft, I would like to go for the DTPA scan.
Okay, I have a bit of a correction here. The first part is correct. Wherever you have a normal creatinine, in fact, let me come a little before that. Wherever you want to have an absolute GFR estimation, be it in case of donors, be it in case of chronic kidney diseases, or be in cases of patients who are being subjected for chemotherapy, you will use only technetium DTPA scan. No other scan will give you GFR value because DTPA is an exclusive glomerular agent. So wherever interest is in GFR, obtaining the GFR as a quantitative value, DTPA scan is the preferred scan. You use MAG3 or EC in pediatric patients under age of 1 year. You do not do a DTPA scan in those patients. 6 months is the theoretical cutoff, but for all practical purposes, any patient under the age of 1 year should undergo a MAG3 or an EC scan and not a DTPA scan. The reason being the renal maturity is not achieved until the age of 6 months to 1 year. Point 1. So point 2, the EC as a radiopharmaceutical or MAG3 as a radiopharmaceutical has higher protein binding and hence it stays more in the vascular compartment. Whereas DTPA is known to extravasate through the vascular pores that are present, and you will have a lot of background activity. So your images will not be very clear. Your differential function estimation of left and right kidney will not be very accurate if you use a DTPA in an infant, in a patient who is less than 1 year of age. So all those patients who have age of less than 1 year, you will use an EC or a MAG3 scan. And our third point is wherever you have compromised renal function, the patient's serum creatinine is 4 and 5 and 7. In those cases, if there's hydronephrosis and then you want to suspect, you want to rule out an obstructive system, in those cases, you will use EC or MAG3. Again, because the DTPA extravascular excretion will be high, as is the kidney function is compromised. So you'll have a lot of tracers circulating in the body. You will get excessive background activity. You will not have good images. The background will be very high, and hence you will not definitively be able to comment on the function and obstruction. So these two specific conditions where you have also in transparent renogram, EC or MAG3 is very good, but you can use DTPA also. Otherwise, an adult healthy person who has a normal cortical function, whose GFR is normal, even then you want to rule out an obstructed system, you can still use DTPA. If the creat is high, you should go for EC or MAG3. All right. So if this is a 3-year-old child, for instance, and when will you ask for a follow-up scan? How will you follow up a patient with left-sided hydronephrosis, for that matter, with a renogram showing an obstructed pattern? What would be your cutoff for intervention? When will you like to follow up these patients with the renogram?
Sir, if differential function is greater than the 10% of each kidney, then we would like to intervene by the pyeloplasty or to remove to relieve obstruction. And after that, after 6 months, we can do the follow-up scan to see the improved function. But as soon as pyeloplasty, there is a rapid increase in the cortical function, but tracer drainage is not as good as compared to the cortical function. So we would like to do it after 3 months or 6 months.
All right. So yeah, so the differential function cutoff for a renogram that we call as normal is 44%. And typically when the patient has differential function of less than 40, that is when we generally say that this function is compromised enough along with the drainage pattern and along with the USG parameters. If the pelvic diameter is beyond a level, you factor in all these things and then you decide to intervene. You write with the follow-up scan. We typically recommend a follow-up scan at 3 months. However, if for some reason you choose to observe a patient on a renogram which has a differential function of less than 40%, then the follow-up scan should be at a closer interval, usually 3 months. And post pyeloplasty, oftentimes you will see good cortical function, but you will not see a very smooth drainage as it is in a non-obstructed system. And that pattern can persist for an indefinite period of time post pyeloplasty because the renal pelvis loses its pliability. So you will never see a completely normal, you'll rarely see a completely normal drainage pattern with the kidney in those cases. Right, so I'll go to the next case. This patient was this scan is a scan of indirect radionuclide cystography. This is primarily done to rule out reflux. If you look at this kidney, on the left side, there is tracer uptake in the left kidney, there is drainage, ureter is prominently visualized. The right kidney is not visualized, but on the delayed images, as you were saying, there is tracer reflux coming from the lower side. So this was not a transplanted kidney, this is a radionuclide cystography. So you do radionuclide cystography is in two ways. One is a direct radionuclide cystography where you instill isotope into the bladder from retrograde, and then you see filling phase, and then you see if there's reflux on both sides. Second way of doing it is to do a conventional renogram and image the patient as the patient continues to void during the renal scan acquisition. So this particular case was reflux. Do you commonly use radionuclide cystographies for reflux?
No, sir. Most commonly used is micturating cystourethrophy,
Right.
which can give the anatomical
Correct.
contour of the bladder as well as any abnormality like diverticulitis and other parameter along with urethral parameter also we can assess with micturating cystourethrophy.
Correct. So MCI is typically preferred. We recommend doing DRCGs, especially with follow-up cases once you've diagnosed or once you've corrected them, because one, this can pick intermittent refluxes. Patient is continuously voiding for 30 minutes or whatever duration that the scan goes on. You can acquire the scan simultaneously without having the necessity to shoot films continuously. One isotope injection and you can acquire films simultaneously. And second is the radiation exposure that the child receives from a DRCG is typically 1/10 that of an MCU. So if you want to do repeat studies, if you want to keep the patients on follow-up, having done the baseline procedure, these are very good scans to go about.
Yes.
Okay, renal transplant evaluation. This is an important question. You read the scan again. In the scan, we will see the scan in the same three fashions. First is the perfusion phase, that is the flow phase. The second is the cortical uptake and excretion phase. The third part is the renographic curve, and then the quantitative parameters. Points to remember here. You typically see the aorta and then the iliacs. The transplanted kidney has to be seen within 2 to 4 seconds of visualization of the iliac artery. And it has to shine brightly like this. You should be able to make out a kidney on the perfusion images. That is when you call this as a good or a normal perfusion. This particular patient had good perfusion, good uptake in these phases, but the curve is going upwards. You commented that this was an obstructed system, but if you look at this particular case, the tracer accumulation is all in the renal cortex. It's not in the renal pelvis. It's a parenchymal tracer accumulation, which typically, since we are using an EC or a tubular agent here, the parenchymal retention of tracer will mean tubular necrosis. So this patient is a case of vasomotor nephropathy or a tubular necrosis and not an obstruction. In an obstruction, you will typically see tracer retention and accumulation in the renal pelvis, which is at the center. Here, the tracer accumulation is entirely in the renal parenchyma, in the cortex, and not in the center.
Yes.
All right. So what are the indications for doing a renogram in a renal transplant evaluation? When do you use a renal scan typically?
You can check the acute tubular necrosis versus graft resection.
Okay, so clinically presenting as?
Decreased creatinine and clinically pain and raised creatinine and decreased output.
Decreased urine output and elevated creatinine or rising creatinine. So,
and anastomotic leak also.
Yes, of course, you can do that as well. Sure. So a transplant renogram typically in a case of vasomotor nephropathy or an acute tubular necrosis, will show excellent perfusion. The perfusion is not compromised. The perfusion is always good. Will show good tracer uptake. The cortical function of the kidney is always good in these cases. But the excretion will not happen from the parenchyma. All the tracer will be accumulated in the renal cortex. It will not be excreted into the pelvis. There will be minimal excretion, of course. It won't be like no excretion, but most of the tracer retention will happen with the parenchyma. In contrast to that, this particular case, you're seeing the aorta, you're seeing the iliac vessels, but there's very, very poorly visualized transplant kidney. 2 seconds per frame. So 2 seconds, 4, 6, 8, 10th second, you're starting seeing some activity here, which means the perfusion to this kidney is greatly reduced. You look at the second phase, there is kidney visualized, but it is not as bright as I expect it to be. Also, if you see, there's a lot of background activity. You see so much of gray haziness all around. Look at the renographic curve. You don't have a good up peak. You don't have a good excretory phase. Neither do you have a good rising phase. It's all flat. The amplitude is very poor. And if you look at the values, the DTPA GFR is typically 11, which is very low. So this is a classic case of acute rejection. So a vasomotor nephropathy will show very good perfusion, good uptake, good function with poor excretion with parenchymal retention of tracer, whereas an acute rejection will typically show poor perfusion, poor function, and it will continue to excrete urine in whatever amounts it will be, but the function will be greatly reduced. So perfusion phase is the most crucial phase, followed by the uptake phase. What is the time frame for a typical vasomotor nephropathy to set in?
Sir, I don't know.
When do you often see acute rejection? Hyperacute rejection is of course on the table. When is acute rejection?
1 to 6 hours after the transplant.
Within 24 hours typically. Yeah, 24 to 48 hours is when you. So first hyperacute rejection is on the table within 1 hour. Acute rejection is within first 24 to 48 hours. ATN typically sets in by 7th day. And then when you do a renogram at this phase, you always ask for a follow-up renogram. A baseline renogram and a follow-up renogram showing further deterioration in function will again lean towards rejection. But a baseline renogram showing a poor excretion, but a follow-up renogram showing improvement in function will again lean towards a vasomotor nephropathy. What isotope will you use? What pharmaceutical will you use for a renogram in transplant evaluation?
EC.
Preferably EC.
EC.
Yes, preferably EC, unless you want to know the absolute value of the GFR. Otherwise, EC or Mach3 both are used. In India, EC and Mach3 both are available. EC is available locally. It's made locally. That's why it's cheaper for the patient. Qualitative-wise, quantitative-wise, imaging-wise, there's really no difference. So EC or Mach3 can be used completely interchangeably. All the quantitative and qualitative parameters are very similar. Yeah, I think I'm done with the cases. If you like to, I can go through a bit of a theory, or we can have more discussions.
I'll just ask Dr. Pankaj Maheshwari or Dr. Hudedar is there. If they want to ask any question regarding any clinical question on Hiren Sodha, then we can ask them. Otherwise, you can go with the discussion. Pankaj bhai?
Nice, sir. I think things are going good.
Okay, so
Dr. Parag, I just wanted if you can go to the case number 2.
Yes, sir.
In this, how do you calculate the cortical transit time?
So cortical transit time, it requires two things. One is normal renogram, which we do is with a whole kidney ROI. You draw the region of interest on the entire kidney. Whereas with the cortical ROI, you draw only a 2-pixel ROI, limiting only to the cortex of the kidney. You don't include the deeper cortex or the pelvis at all. Second thing is, of course, there are softwares within the machines which estimate and give us the mean parenchymal transit or cortical transit.
Acha, my understanding was, say, if we look at the second row, the 2-minute films, the approximate renal pelvis being seen in the third or fourth image. So probably we can say that CTT is less than 4 minutes. Would that be right or wrong?
As a very rough estimate, yes, sir. I mean, that's how so if you were to look at that qualitatively without getting a particular value, then you look at the cortex of the kidney, the outer ribbon, and you see how fast this transits into the pelvis. So that is a rough ballpark estimate of the cortical
seen in the third image.
Yes, sir. You can see progressively and whichever images in the earlier phases. So the excretion from the cortex into the medulla typically starts from the third minute, second to third minute, between 2 to 3 minutes. And that's why your peak is at 2 minutes, 2 to 3 minutes. Because all the tracer is accumulated at this and it starts excreting. And that's why the curve starts going down. So roughly.
Can you explain Nora once again?
Yes, sir. So I have a slide, in fact. So what happens typically with these cases is if you have a passive pelvic ectasis, the tracer is accumulated in the pelvis, which theoretically is a non-obstructed system, but because of high pelvic pliability, the tracer continues to pull inside the renal pelvis without being thrown out. And hence, if you go purely by T-half, you will call it an obstructed system. So in such cases, you calculate something called as NORA, or normalized residual activity. So NORA can be calculated at 60 minutes, 30 minutes, 20 minutes. There are various papers who have done at all these time points. What we typically follow is you take the counts on the kidney at its peak, typically at the second minute. And then you take the counts on the kidney on the 60th minute image, that is on the delayed image. And you take a ratio of both these counts, 60 minutes to 2 minutes. So technically, if the system is non-obstructed, your 60 minutes count will have to be lower than your peak counts. So this cutoff value is 0.5. If the NORA is less than 0.5, it is a definite non-obstructed system. If the NORA is more than 0.7, it is highly likely that it is an obstructed system. Whereas if the NORA is between 0.5 to 0.7, it is still an indeterminate system.
And when we are calculating NORA, we are not giving any diuretic.
No, it's the same injection. You just acquire a delayed image. NORA, diuretic is given, of course, sir. It is on a diuretic renogram.
Okay.
But diuretic is given only once initially. You don't repeat the Lasix in the later post-delayed images.
Right.
Just I want to know about
Thank
this
you.
protocols.
Sorry.
Okay, Parag, you answer him, then we can go ahead with your presentation.
Sure, sir. Yes, please go on.
This protocols answer F-15, F0 and F+15, F+20 protocols. When it will be used?
Okay, so all protocols have been studied under various indications, but there was one 17-year meta-analysis published which says that F+0 protocols gives the best results comparative to all other protocols. So as a default now, everybody has switched to F+0 protocols. Where you want to avoid Lasix for some reason, you can do the F+10 protocol, because then you can see if the tracer is accumulating, only then you give Lasix. It will not have to be given in every case in that case. So only in those cases you give an F+10 protocol. It is important to continue the renogram for 20 minutes after giving the Lasix. Otherwise, you may terminate the renogram before the maximum diuresis happens. So typical renogram is about 20 minutes. We stretch it to 30 minutes. But if you don't give that 20 minutes extra, then your F+10 protocol is inadequate. So if you're insisting for an F+10 protocol, be sure that you at least ask for a 30-minute renogram. Otherwise, all other cases, F+0 is just as good. In a grossly hydronephrotic system, sometimes F-15 protocol is recommended because you give that extra 15-minute lead time for the diuresis to begin right at the outset when you're starting your renogram, so that you have a maximum diuresis right from the beginning of your study. So in grossly pliable systems, gross hydronephrosis, you can still ask for an F-15 protocol. But otherwise, for all practical purposes, F+0 protocol is considered as a standard now.
Also, we have these details crisis in urology, wherein we want to load the system. So I think in those cases also we do F-15.
We do F-15, yes, sir. That again happens with grossly hydronephrotic systems.
Correct.
Okay, fine, you can go ahead.
All right, sir. I'll just have a brief presentation. 50, 60 slides, but I have gone through So I'll quickly go through some important aspects in these cases. So when we speak of renograms, we typically use something called as a technetium generator. So this technetium generator gives us technetium, which is the isotope, which is the radioactive part of the isotope that we inject. When we do these procedures, we use something called as radiopharmaceutical. Our scans are based on radiopharmaceuticals. Radiopharmaceutical has a radioisotope component and a pharmaceutical component. The radioisotope component, that is the technetium, comes from this generator. The pharmaceutical component is then labeled exogenously within the radiopharmacy lab, depending on the organ you want to study. So your technetium is constant for all these scans. The pharmaceutical, that is the DTPA, can be for GFR, DMSA can be for cortical study, and so on and so forth. So all these scans will be radiopharmaceutical based. In the olden days, we had something called as a renographic probe. In those conditions, you did not have imaging systems. Are my slides visible?
Slides are not visible. You are still sharing initial cases.
Oh, sorry. Can you see them now?
Yes.
Okay. So this is how a typical generator looks like, from which you get the radioisotope, and then you milk this out and you label it with a pharmaceutical to form a radiopharmaceutical. Choice of pharmaceutical depends on the scan that you are intending to use for. For example, if you want to estimate the GFR, you label this technetium with the DTPA and inject. If you want to do a cortical scan, you use the same technetium and you inject and you do the renal DMSA scan. In the olden days, you had something called as renographic probes available. You did not have cameras, you did not have imaging systems. So these probes would be just kept on your kidney areas and they would generate the counts based on curves based on the counts only. And that is why the initial systems which mention obstruction based on the T-half factor in only this parameter for the commenting on the obstruction. If the T-half is elevated, call it obstructed. If the T-half is not elevated, call it a non-obstructed system. But we now know that there are many more reasons for the T-half to get prolonged. For example, if the renal cortical function is impaired at the outset, your T-half will be prolonged, and so on and so forth. So that's why we then move from this to imaging systems. This is a typical SPECT system, a gamma camera system, which we call as. This is the machine used for all the renal scans, static, dynamic. You do a renal DTPA scan, that is a dynamic study, because you inject the isotope. The scan is acquired as the injection is going on and as the kidney is accumulating and secreting tracer. And DMSA is a static scan. You inject the scan, you inject the isotope, and the scan is done typically 2 hours later when the tracer has gone and fixed to this renal cortical system. We, of course, have the PET scanner, which you are all well versed with. This is a different talk entire altogether. I will touch that upon later on. Now, this is the typical nephron. When you speak of a technetium DTPA scan, this is a pure glomerular agent. So whenever you want to measure glomerular function, GFR, you have to use technetium only. For all other indications, you have the technetium DMSA, which fixes to this. It does not get secreted or excreted to this. It goes and fixes to these cells. And hence, it will demonstrate the picture of the renal parenchyma or the renal cortex. Whereas your MAG3 or Hipuran or all those things are typically excreted through the tubules. A very, very negligible amount goes through the glomerulus. So these are all tubular agents. So brief indications: to look for infection, to look for obstruction, renovascular hypertension, transplant evaluation, and GFR. And depending on the site of localization, for obstruction, you prefer an EC or a MAG3. Where you want a GFR, you prefer a DTPA always. Infection imaging is with DMSA. Transplant can be with DTPA or EC. Creat usually is typically higher when you need a renogram. So EC or MAG3 is always preferable in those conditions. And renal arterial stenosis, you can use DTPA as well as EC. So I'll briefly touch upon the parenchymal cortical imaging. You use a renal scan or a DMSA scan when you want to identify significant urinary tract abnormalities. For example, if there are recurrent urinary tract infections and you want to know if there is renal cortical involvement versus just lower urinary tract infection, you use a DMSA scan. An isotope is typically injected 2 to 3 millicuries as an IV dose. The radiation exposure to the patient is 0.8 millisieverts, which is really a negligible figure. It's safe to be repeated. Injection waiting period of about 2 hours, followed by a scan, which typically takes about 10 to 12 minutes. A normal renogram or a normal DMSA scan will look like this. Good contours, good uptake in both kidneys, symmetric appearance in a bean-shaped kidney, negligible background activity, a normal renal scan. And compared to this, you're seeing a nice photopenic area in this condition is a typical case of a pyelonephritis, possibly acute pyelonephritis. And this is how a scarred kidney would look like. The contours will all be distorted. There'll be volume loss, there'll be shrinking, there'll be reduction in differential function of this kidney. So a scarred kidney would typically look like this. The case which I showed, baseline scan showing a defect, antibiotic, and a follow-up scan which shows normalization of this defect, improvement, and this was a focus of pyelonephritis. This can also be used for an accurate estimation of differential function in cases of ectopic kidneys. This was a pelvic kidney, a native kidney which is again small shrunken. If you do a technetium DTPA scan in this case for evaluation of differential function, the ectopic kidney is likely to overlap on the urinary bladder. So your curves will not be very reliable because I cannot differentiate based on the region of interest that I draw here, whether it is activity counts are coming from the bladder versus the activities coming from the ectopic kidney itself. Hence, in this case, a DMSA scan is a more reliable predictor of a differential function calculation. Also, towing this point, also in patients where you have gross hydronephrosis, where you want to decide whether you want to keep this kidney or knock it off, where you want a more objective and accurate estimation of differential function, a DMSA scan is a very good scan for pure differential function estimation. Along with that, of course, if you want to know the dynamics, obstructed versus non-obstructed, then you do an EC scan. But otherwise, if pure differential function is your concern, a DMSA scan is always more objective and more accurate than a DTPA scan. Yeah, this pretty much, okay. So this important point here between the EC and the DTPA, if you see if the plasma binding, the DTPA plasma protein binding is less than 5%, which means a lot of tracer is prone to extravasate from the vascular compartment into the non-vascular compartment, whereas a DMSA, whereas a MAG3 has a very high plasma binding, which means a lot of this tracer will be retained in the intravascular component, which essentially means that the background activity with a MAG3 is far lower. And this has a great relevance, one, when the renal function is not mature, when the renal maturity is not reached, as in infants less than 6 months of age or 1 year of age, or patients with already impaired renal function where the creatinine is high. So in all those cases, always prefer an EC or a MAG3. For all other cases, you can do a DTPA conveniently. This is a classical normal renogram. You have the flow phase, the uptake phase, and the excretion phase. A symmetric renographic curves, left and right kidney, showing a good peak, showing a good excretion. The excretory curve will be called normal only when it is an exponential curve promptly excreting. Any deviation from this, a mild fullness in this, will always indicate that it is an indeterminate pattern for obstruction or it is an obstructed system. I'll come to the patterns of renographic curves a bit later. Here. So a normal curve will have a normal uptake, a good peak followed by rapid excretion, and the classic obstructed system will show a rise, and despite the diuretic, it will continue to rise. This is a hypotonic system or a reservoir effect, which we typically know as the tracer will stay accumulated in the renal pelvis. It will stay there, but the moment diuretic effect kicks in, it will start showing excretion. Equivocal, after the diuretic, there is excretion of the isotope, but not enough to call it a non-obstructed system. And sometimes in a grossly obstructed system, or especially in a VUJ obstruction, you have a delayed decompensation, which is a rare type. The isotope is excreted from a region of interest, goes down, and from there yo-yos back into the renal pelvis. And that's why it shows a secondary rise in the curve in a later phase. But again, as I said, renographic curves by themselves are not very reliable indicators for calling the system obstructed or non-obstructed by themselves. You always have to look at the renographic curves the differential function as well as the qualitative images in concurrence and not in isolation. So this was a typical patient of right hydronephrosis, tracer accumulation in the right pelvis, but there is subsequent accumulation, excretion of the tracer. So there is right hydronephrosis, but it's a non-obstructed system. And in this particular case, there is left hydronephrosis, there is accumulation of tracer persisting on the delayed images and classical obstructed system. Now, in this particular case, he was a 5-month-old child with antenatally diagnosed right hydronephrosis. The left kidney shows good perfusion, good uptake, the renographic curve is good, differential function is good, whereas the right kidney shows a hydronephrosis, focal tracer accumulation within the pelvis, which is not excreted by the end of the dynamic images. If you take the delayed image in this case, the post-wide image as well as the delayed image shows retention of tracer, and this is again a case of a classical obstruction. So delayed images are important. And contrary to that, this is the case that I showed earlier. Hydronephrotic left kidney, good function, renogram of rising pattern or an obstructed pattern, but on the delayed image, the post-wide, the images which were showing tracer accumulation are now showing tracer excretion. If you see the intensities of both kidneys, they're roughly equal, which means they're more or less excreted. So this was a case of hydronephrosis, but sluggish and non-obstructed drainage. And this is what we call it as a reservoir effect. In such cases, a NORA is very, very helpful for making this scan more objective. You take a ratio of counts at 60 minutes to a count of 2 minutes, and a value of less than 0.5 will indicate a non-obstructed drainage. This was another case, left-sided POJ obstruction. You're seeing a hydronephrotic left kidney, enlarged left kidney with the renographic curve showing an obstructed pattern, the right kidney showing good cortical function, the renographic curve showing a non-obstructed pattern. On the delayed image, again on the left side, there is significant tracer retention, and the NORA in this case was more than 1. There was a rather further accumulation of tracer in the left kidney, and this was a classical case of obstruction. I'll skip this slide. Okay, this is another case where if you see the right kidney, there is hydronephrosis, there is drainage of the isotope from the right kidney, but the curve is not very classically non-obstructed, although it's coming down. There's no peak and there's slight blunting of this curve. In these cases, we typically take a cortical ROI. It's a thin region of interest drawn on the renal cortex, not including the renal pelvis, not including the deeper portion of the renal cortex, and then you get a classical non-obstructed curve. So it may often happen that a whole kidney ROI may show you an indeterminate pattern or an obstructed curve, but if you take a cortical ROI, which typically demonstrates the cortical transit time in a way, you will end up getting a non-obstructed curve. It basically indicates that the transit of tracer from the cortex to the pelvis is normal, and hence it's a sluggish system, but a non-obstructed system. So when do you do a renogram typically? You have a severe degree hydronephrosis at 4 weeks of age. You have a hydronephrosis at birth, but which is progressing on serial ultrasounds. And you can use MAC3 or EC scans until 6 months of age, or practically for up to 1 year of age, following which you will start doing the technetium DTPA scans. What are the indications for calling a system obstructed on a renogram? One is, of course, the good old T-half. A T-half of more than 20 typically indicates obstruction. A NORA value of higher than 0.7, prolonged cortical transit time, and a differential function of less than 40% if the system is a unilateral hydronephrosis. If it's bilateral hydronephrosis, your both kidneys are going to show a fall in function, and hence the relative function will still be maintained, and it will falsely depict a normal differential function. So in an isolated system, isolated hydronephrosis, a differential function of less than 40%, along with all these parameters, will favor a typically obstructed system. This was an example of a cross-fused ectopia, the right kidney and the left kidney flowing down in the pelvis, both showing non-obstructed drainage, of course. Okay, so evaluation of renovascular hypertension. With the current times, the Doppler is a very good system for diagnosing renal artery stenosis, but renovascular hypertension captopril renogram is used, one, to assess the hemodynamic significance of a known stenosis. Second, is the hypertension related to the renovascular narrowing or not? It is not as useful nowadays for diagnosing renovascular hypertension because your Doppler now performs a much better role. This is used for assessment of hemodynamic significance of the renal artery stenosis. There are qualitative and quantitative parameters for this. I think I don't need to go into those details because it's not very commonly used now. In a sense, what we do in this scan is we do a baseline renogram scan, then follow-up scan, we inject enalaprilat to the patient, and then we acquire the renogram again. If there is a hemodynamically significant renal artery stenosis, the angiotensin converting enzyme normally takes care of the renal perfusion and function. But when you give enalaprilat, you block the renovascular function. And that is why the renal function starts deteriorating. And you see a difference between these cases. Now, if you see in this case, the baseline scan, left kidney good, right kidney good, excretion is good, no problem. You do a post-enalaprilat scan, the left kidney is still good, but you start seeing focal retention in this particular case on the right kidney. And this was a classic case of a polar renal artery stenosis, a segmental renal artery stenosis. It's not very commonly used these days, so I'm not touching upon much. Transplant renogram is something you should be using upon. Transplant renogram, you have complications of which the renal scan is most useful in cases of rejection, whether hyperacute, acute, chronic. 2 is in cases where you have suspected obstruction of the transplanted kidney. 3, where you are suspecting infection of the transplanted kidney. And 4th, of course, is your classic vasomotor nephropathy versus acute rejection. This is one parameter that you should know. There are various quantitative parameters that are derived for evaluation of a renal transplant, of which the Hilson's perfusion index is the most commonly used. What is this parameter? It's very roughly put, it is the amount of isotope that reaches the renal artery, and of that, how much of it reaches the kidney. That is the simple. If the perfusion, if whatever is coming to your iliac artery is going to your kidney, means that the function is, if the perfusion is good. If there is any narrowing in the artery, that means your isotope is going in the iliac artery, but it is not going to the renal artery because of the renal arterial damage. It is a simple estimate of that. So you take mathematically, you estimate the area under the curves. You draw ROI on the iliac vessel, you draw ROI on the kidney, and you see how much is the area between the two, and you calculate the index. A Hilson's perfusion index of less than 150, it means there is no rejection. A Hilson's perfusion index of more than 200 is a definite rejection. 150 to 200, again, is an indeterminate borderline system. For this parameter to be estimated, the renal scan has to be acquired in a very good way. Because if your renal iliac artery itself is not very well visualized, if the bolus that you are injecting is not good, then your renal transplant will also not show a good perfusion instantly. So the technique of the scan for this particular quantitative parameter is very, very crucial. Second, you can also have a visual estimate for the function. As I said, you look at the aorta, you look at the iliac artery. Scans are typically acquired at 2 seconds per frame. Once you start seeing the iliac artery, your kidney should start appearing within next 2 to 4 seconds. And by 4th or 6th second, it should start appearing brightly. In this particular case, you're seeing the vessels, you're seeing the kidney that is showing good perfusion, bright uptake. The transplant perfusion is normal in this case. Again, this case shows further there is good cortical tracer accumulation, then there is excretion into the pelvis, and then you start seeing the urinary bladder. The curve, a rapid upslope, followed by a peak, and then followed by rapid excretion. So this is how your normal transplant renogram will look like. A good perfusion is critical, followed by good uptake and good excretion in the later phases. Versus this patient, which has excellent perfusion, again, the vascular system is well visualized, the kidney is visualized brightly, uptake is good, but all the tracer is accumulated in the renal cortex. There's no tracer seen in the renal pelvis and very minimal tracer seen in the bladder in the later images. Renographic curve by itself looks obstructed, but all this tracer is within the renal cortex and not in the renal pelvis. So this is a classical description of a vasomotor nephropathy or an acute tubular necrosis. You will see good perfusion, you will see excellent perfusion, you will see good uptake, good cortical function, and excretion is poor. Versus in this case, okay, now this was a case which had rising creatinine, reduced urinary output. Day 6 post-transplant, renogram showed good perfusion. The uptake was good, but the excretion wasn't all that great. Renal parenchymal tracer retection. But because of the good perfusion, a classical ATN was labeled in this particular case, and we did a serial follow-up imaging in this case. Baseline function, observe the function, observe the renographic curve. Second scan, day 14, the perfusion is still maintained, the uptake is good, renal function is improving, the drainage characteristics are improving. And day 29, excellent function, perfusion is still very, very good, and renal drainage is also improving, although not completely normal. So this is how your typical renal transplant with the vasomotor nephropathy will classically progress. Whereas if you do in a case of rejection, it will show the exact reverse sequence. You'll show poor perfusion, it will get poorer, you'll show poor function, it will get poorer, and the excretion will be also poor. A classic case of renal transplant rejection, poor perfusion in this case, reduced uptake, reduced GFR, renographic curve of parenchymal dysfunction pattern where you don't have a peak, where you don't have a well-defined excretory phase, excessive background circulation, a classic case of acute rejection. Again, another case, barely any kidney seen here. If you see, if at all, some uptake in the delayed phases. And next indication for transplant evaluation is renal obstruction. A hydronephrotic system, good perfusion, good uptake, good function. The kidney is functioning optimally, but the excretion is poor. In this case, if you see, all the tracer that is accumulated is in the renal pelvis, and the renal cortex is showing clearance of tracer. So this is still a rising renographic curve pattern if you compare it to the previous one that we saw. But in this case, the tracer accumulation is entirely in the renal pelvis and not in the renal cortex. So this was a case of obstruction. There was one important thing that I would point out here is this system had a classic hydronephrosis, clinically obstruction was suspected, but when we did a renographic curve, initially it showed tracer accumulation in this case, but if you see the delayed image, there is washout of tracer from the pelvis. So we called this system as a non-obstructed but hydronephrotic system. And then the question classically was asked, if there is no obstruction, why is there so much obstruction? If there's no, why is there so much hydronephrosis? And then we referred to some literature, and this an additional point is what we figured out. In these cases, you repeat the renogram in a standing position. You improve the renal drainage, you give it a more gravity dependent system. So when we did the renogram in standing position, this is the obstruction unmasked, and you started seeing a significantly higher retention of tracer in this case, even on post-void and delayed images. So in renal transplant evaluation, when you get a hydronephrotic system, but the renographic curves are not so demonstrative of an obstruction, you acquire some images in the standing images also, the erect, enforce it with a gravity-dependent system. Is when you unmask the obstruction, as was with this case. Now, if you see in this renogram, here, the perfusion is good, the uptake is good, but something is amiss in this renogram. If you see the pelvis typically in the urinary bladder region, this is not a very well-defined pelvis. You're seeing a very hazy kind of picture and irregular, whereas in other cases, you will see a bladder activity typically well circumscribed like this. So that brought out a query, and then we acquired a tomogram in this case. In fact, what we figured was there was no activity in the urinary bladder itself, and whatever activity we were seeing was the urinary leak into the pelvis. So another indication for evaluation of renograms in transplants is for assessment of transplant leaks. Another case of renal transplant leak picked up by a SPECT imaging. You see tracer outside the focus of the kidney, and the corresponding SPECT CT images show tracer accumulation outside the kidney, which is a typical sign for urinary leak. Again, another patient, the drain showing high creatinine values. You did a transplant renal evaluation with a tomography, and you're typically demonstrating urinary leaks in this condition. And one last indication, you have patients with pyrexia of unknown origin with a transplant. Sometimes you end up picking something like this, a focus of uptake in the renal cortex on the PET imaging. The good old DMSA shows a very classical focal defect in this region. This was focal pyelonephritis / infection of the transplanted kidney. I think I'll end at this. That's briefly about all the renograms. I have two questions here. Let me see. How often do you need to do DMSA in children without any breakthrough infections till 6 years of age? No, thereafter we do not do it once there's no documented. Typically, recurrent UTIs is where we use renogram DMSAs. Otherwise, as a routine, it is not required. If creatinine greater than 3, okay, what is the cutoff of creatinine for DTPA, DMSA, MAG3? DMSA has no cutoff for creatinine. Whatever the creatinine, you can still do a DMSA scan. And with an EC or a MAG3, yes, typically 3 is the value that we use, beyond which we prefer doing an EC or a MAG3. And age cutoff. Anything less than 1 year, we prefer to do an EC and MAG3. Anything greater than 1 year of age with a normal cortical function, I think DTPA is good enough. Any more questions?
So could you review what is the criteria what you will take in for an obstruction? I would think is a NORA or T of time greater than 20 minutes.
I'll go back to that slide. Yeah. So T half of 15 to 20 minutes is typically the range, but classically more than 20 minutes will be obstruction. A NORA at 60 minutes. So you need to mention when the NORA is calculated. A NORA at 60 minutes value higher than 0.7. A prolonged renal cortical transit time either evaluated based on the system or just a visual interpretation. And the differential function falling less than 40%. The last point is important. With a unilateral hydronephrotic system, if you have bilateral hydronephrosis, the absolute differential function will not be very helpful because you'll have differential function falling on both kidneys. On serial imaging, when we do renograms, you do a baseline renogram now in a case of hydronephrosis, and you do a follow-up renogram, say 6 months later. A fall of differential function of more than 5% is considered to be significant, because until 5%, you allow some statistical variation. Depending on the region of interest, depending on how you process the images, depending on the acquisition protocols, sometimes there can be some variation, but up to 5% fall in differential function is considered within the physiologic range. Any subsequent fall of more than 5% should be percentage points should be considered abnormal.
We consider the this function or the curve, which is the main for the whether it's progressing or it's stabilizing or declining.
Both. I mean, you typically look at all these parameters, not just one parameter. But if you were to pick one critical factor, I think the differential function falling is the single most important predictor. And invariably, when you have fall in differential function as a result of hydronephrosis, your curve parallelly will go worse.
How much significance do we give to T half in today's time?
Not much. So by itself, definitely not at all. But not much as such, because there are a lot of factors which can cause a prolonged T half. If your parenchymal function itself is delayed, that will also cause a poorer T half clearance.
Yeah, because there are some reports of T half as high as 75 being normal.
Yeah, it's quite likely. So
Yes.
sometimes we also see that if you have a single kidney where there's a cortical compensatory hypertrophy, in those cases, typically you will see a T half prolonged, but the excretion is good. So by itself, it's not a very reliable factor. It came as the first parameter when you had only counting statistics available. These days, no, I wouldn't go much by the T half value by itself.
Excellent compilation. Thank you.
Thank you so much, sir. I'm available for questions anytime. If you feel free, please connect. Please feel free to connect, and I'm here to answer your questions anytime. Okay, shall I stop sharing the slides now? I mean, do we call it off?
Yeah. Any other questions anyone wants to ask? Okay.
I have a question here. How often do you need to do DTPA scan with solitary functioning kidney with mild hydronephrosis in asymptomatic child? No, I am not sure I quite get this question. How often do you need to do DTPA scan with solitary functioning kidney with a mild hydronephrosis in asymptomatic child? So you do one baseline renogram scan. If the function is good on the scan, if the drainage is non-obstructed, you typically follow up these patients with ultrasound. And if there's a significant progression on the ultrasound, then you can perhaps come back and do a renogram. But as a routine, I would not recommend doing renogram for screening purposes. An ultrasound with no radiation is probably your preferred modality.
True.
I guess that's it.
Yeah. You want to ask any particular question, any clinical related to this student? You can just ask if you have got.
No, sir. I think I'm pretty much covered most of it during my initial scans.
Yeah. Okay then. If there are no questions, then we'll stop here. Parag, thank you very much.
Pleasure,
Dr.
sir.
Parag is our head of the department in nuclear medicine, and he's an excellent orator, very learned, and he has really described and given most of the description of all these scans, and he has solved many of the questions. So thank you, and we will call you again for
Yes, sir.
other presentation.
Pleasure,
Thank
sir.
you very
Thank you,
much.
Parag. Thank you. So good for the students. Thank you so
Welcome,
much.
sir. Welcome, sir.
Parag,
Yes, sir.
only thing is, let everyone this thing leave, and at the end you press the leave, so then the recording will not go away.
Right, sir. Right, sir.
Huh?
Sure. I'll hold on. Sure.
Yeah.
Sir.
Stop करा आता चला लय झालं.
Okay. Good night, everyone. Thank you. Thank you very much.
Yeah, Parag sir, kindly end the session. In the corner, there is a end the session.
Okay.